Good morning, everyone, since we're not quite good afternoon yet. I'm James McBrayer. I'm CEO of Cyclomedica. I want to welcome you all here today. This has been organized as we're not approved in the U.S. This was primarily presenting some of the clinical work that we're doing around the world, as well as some of the research that we're involved with Technegas. I just do want to emphasize that Technegas, it's an investigational drug in the U.S. and not approved for any use by the FDA at present. The information is for educational and scientific purposes only and not intended for promotional purposes. So anybody raise your hand if I start drifting towards that way. We have a great lineup of speakers. I'll introduce each one in turn today. But as far as our symposium today, the emphasis is on diagnostic imaging with Technegas. Technegas is available in 64 countries around the world. And again, I want to emphasize that this presentation is an encore presentation of clinical information that's been published and that's already out or has been presented in prior seminars or journals. I'd be remiss in not emphasizing that the speakers here today are from Australia, where Technegas was first invented in the late 80s, in France, where is one of our largest markets in Europe, and in Canada. And I just want to emphasize that this year is our 20th anniversary since Technegas was available in Canada, and I'd also be remiss in not recognizing Lynn McLaughlin, for anyone from the Canadian group there. Lynn has been with us ever since day one with Technegas in the Canadian market, so I want to thank Lynn for her efforts. I'm not going to go into any detail on Technegas other than to say it's a nano-sized particle. Greater than 80% is less than 1 micron, and because of that, it acts as a pseudo-gas. If you want to know more about the technology, please come by and talk to us at booth 5064. We'd be more than happy to go a little bit more in detail about how Technegas is produced. Again, I'm not going to go into any more details than what's already been written out there. When you look on that screen, there's a couple of references there. Technegas is referenced in the European Journal of Nuclear Medicine, in the EANM, and in the Canadian guidelines as well. This has probably been one of the most frequent questions that we've been asked. Where are you up to with the FDA? And this is not a promotional, this is just information only. We had a complete response letter that the FDA issued. They had some very specific things, additional information that they requested from us. We completed that response and submitted that at the end of March this year, starting a 6-month review cycle. Our PDUFA date for the FDA is the 29th of September, and in between that, we have an inspection of our manufacturing facility on July 31st for 2 weeks, and we're actively engaged with some Q&A with the FDA. I'm just going to briefly talk about, if you look in the journals, you'll see what we're best known for in diagnosing pulmonary embolism, but we're also engaged in advancing the use of Technegas beyond what we're best known for. Those are some of our activities that we have going around the world in the expansion of Technegas beyond pulmonary embolism. So straight to the speakers. We're very fortunate to have an exceptional lineup today. The first speaker today is Professor Dale Bailey. I'll let you read for yourself on that. When you do a PubMed search on Technegas, you'll see Dale's name appearing in many of those. And most recently, he co-authored a paper that appeared in the Journal of Nuclear Medicine earlier this year with Dr. Jeff Curry. And as I understand it, I think Dale's going to be sharing his experience over several years of use of Technegas and lung imaging in general. like to welcome Dale to the
Several
podium.
decades.
Several decades. Dale, would you come up, please?
Thank you, James. Hello, everyone. I hope today is going to be a really historic workshop here at Symposium. Historic for especially our US-based colleagues, because I hope this is the last time I have to talk to you about Technigas when you don't have access to it. Hopefully, when we come back next year, we'll be sharing our experiences together about using that. So, my talk, somewhat provocatively, I guess, titled Lung VQ Imaging in the 21st Century. And I'm just going to walk you through how we got to the point we are today, and now that we're there, what we can do with some of the technology. But I want to go back to the last century to start. And as James mentioned, Technigas was invented in the mid-1980s in Canberra by a physicist called Bill Birch. He had the vision to he'd been trying to work with nebulized solutions for a long time, and he wanted to get beyond that, and he started heating up saline with technetium in it and seeing what happened to it, and he came upon what's become Technigas. But I also want to acknowledge the really pioneering and visionary work by one of the technologists in Canberra at the time that Bill was working with. His name is Chris McLaren. I did my early training working with Chris, and he's a great character but also had the vision. And I think it's really impressive to look back at this first abstract that was ever published on Technigas, and in an era where we were doing planar imaging, we were probably only using SPECT for thallium myocardial perfusion at the time. Chris said, you know, here I can give somebody 2 to 3 breaths of Technigas, and what's it going to affect? How's it going to impact? What am I interested in? I want to see if it's going to improve my lung diagnostic capability. I want to see if I can do cross-sectional imaging with the SPECT camera. And some of you old enough might remember that SPECT camera on the left there is the first generation of GE 400 cameras that we started dipping our toe in the water and seeing if we could do tomographic reconstruction with. But he also said, beyond that, would I be able to subtract the 3D SPECT ventilation scan from the perfusion scan and come up with a better perfusion scan and even ratios? So I think if we think back this is over 35 years ago, some of us would like to be at that point today, but Chris was already thinking about it at that stage. Just briefly, how do we use the system? This is what the Technigas generator looks like. We load up the crucible with some technetium, and for us, we're an on-call service, so we have a molybdenum technetium generator in our nuclear medicine department in Sydney. If we get called in on the weekend or overnight, we can just milk that, and so nice to have this on tap all the time that we can always do a VQ scan. As James mentioned, Jeff Curry and I published a paper earlier this year, and Jeff loves doing social media stuff. And he pulled out some interesting figures, and what he did was a 24-hour social media poll about how we're doing our scanning today, and he compared the US with Australia. And you can see that planar imaging was being done 66% of the time in the United States in those that responded, and he had some pretty good numbers, over a couple of hundred. And in Australia, of course, the predominance was with SPECT-CT, with still generating some planar images from the SPECT, and I'll show you how you can do that, but also with using SPECT-CT. So the first question is, when you suddenly get Technigas and you want to start using it, I want to propose to you that you should move straight from planar to SPECT imaging, because life is so much easier in 3D than in 2D, and I hope I can convince you of that today. So we wrestled with this for a long time. How do we make that transition? You'll find that your physicians and your radiologists are very, very good at reporting planar lung scans. They know what to look for, they know stripe signs, they know all those sorts of things. And you suddenly put up cross-sectional images in 3 different orthogonal planes, and they don't know where the segments are, and they get all lost. And so we had to go through a transition phase, and we did a lot of work in this area, and there's a paper that you'll find in seminars on that particular topic to walk you through this transition from planar. But the transition is facilitated and helped by being able to generate some planar images to give your physicians confidence, at least for the first few months or however long they want to do it. And so there's 2 methods for doing that. The simplest method was published by Pierre Reinartz initially, and all you do is you take that SPECT projection data before reconstruction, the raw data, and you take out various images. So you will extract 3 images near the anterior, 3 images lateral, posterior, and so on, add them together. So if you're thinking about a 10-second per projection acquisition, this is clearly count deficient. It's only 30 seconds of data in total, but it's good enough really to have some planar reference images. The method that we developed was a little more complicated, I guess, but being a physicist, that's what we like to do, you know. And so what we did was we reconstructed the images and then we forward projected them through the attenuation map provided by either a CT scan or, at the time, we had a scatter-based method of generating attenuation data, which we published. And we then forward projected them again. And the beauty of this method is that you use all of the data that you've collected from every angle every time you reproject and do that forward projection. And so that was the method of choice for us. And it actually produced some problems for us because the images, when we did that forward projection, instead of having the equivalent of a 3-minute 300K or 500K planar image, we found we had 8 million counts and 12 million counts. And when we tried to do a blinded assessment for our physicians of what a standard planar looked like compared to this, they always knew which one it was. And so I actually had to go through and add noise to the images to degrade them so they couldn't tell the difference. They were that good. But this is the sort of thing. So you can see planar images on the top, done in the standard way, the standard views. This is Patrick's method, the angular summed planar method. You can see they're pretty good and they're really quick to generate. This is the reprojected method using a synthetic mu map, which we derived from the lung scan, and that's been published. Or we could use the CT data, and you can see. And look, they look terrific, these reprojected images. And if you want to keep going with planar, you can do it with very little penalty. So that's a useful thing to know. You can also do some really kind of funky things with it. I found that what you could do is not only generate, say, the anterior and posterior views for the ventilation and perfusion, but if you looked at the cross-sectional transverse image and you actually just blanked out one lung, you just removed it, you could actually generate a single lung view, not only from a lateral, with no shine through from the other lung, you could actually do a medial view of the lung. And so there you can see some medial and lateral views of an isolated single lung by segmenting out and removing the other lung. So there's really interesting things you can do once you've got the technology. When you go to SPECT, you improve both the sensitivity and the specificity over planar imaging. When you go to SPECT CT, you improve that even further. So you can see that the reports here generating over 90% sensitivity and specificities in general, and if you add CT to that, the value of CT is that it helps you to define some irregularity you might see in the perfusion image, and you might encounter it. It might be fluid along the fissure, it might be a lesion that maybe is getting a bit of ventilation but no perfusion, and so it helps you even further. So I think this is the state of the art. This is where we are in the 21st century. So after you make that transition from planar to SPECT, what can you do? Well, clearly you can do co-registration. Once you've got co-registration of your ventilation and perfusion, you can start to do ratio images. As Chris alluded to in his 1986 abstract from our national meeting, you can subtract the ventilation from the perfusion, and so you've got a pure ventilation image now with actually no, pure perfusion image with no ventilation contribution, and then those ratios are very valid. And so there you can see a couple of segmental defects due to emboli shown in yellow on top of the background ratio close to 1. You can start to look at why you're getting areas that aren't perfused, and here you can see some infiltrated disease and sarcoid there. You can co-register to the CTPA, so often you might find that patients had a CTPA, it might not have been conclusive for PE, you might get referred the patient for a lung scan, or it could go the other way, depending on the age of the patient and how well they are. But what we found was really interesting was to put them together, and you can see here, I hope, there's a clot just right in there, and you can see a lovely segmental defect that is distal to that clot, so you can put that together. When you can do the segmentation of the lobes based on the anatomy, you can use the fissures to guide you. You can divide up the lung and start to look at the function that you ascribe to each lung, and that has many different applications, and I'm sure you're going to hear more about that in later sessions. We also use the RT dose fields in lung therapies to use the lung dose as a volume of interest. So we had a 50 gray region defined by the RT beam, a 40 gray, a 30 gray, a 20 gray region. And so we did the volumes of interest based on the RT plan you can see there. And so the images at the bottom show you what the lung scan looks like with the different fields overlaid on top of it. And in that study we were looking at what happened to the lung with increasing dose, and we saw a definite shift of function away from the areas that were getting the highest dose, presumably due to a impending pneumonitis or something like that. From a research point of view, this is a study in an asthmatic done by my colleague Professor Greg King from the Woolcock Institute. Well, this is a methacholine challenge, so the top row shows you the patient who's asthmatic under baseline conditions, but then after a methacholine challenge on a separate day, they've got this regional heterogeneity of ventilation that's nicely shown there. So Greg's very much of the belief that asthma is in general not a generalised disease of the lung, it's more regional, and so he's very interested in this sort of heterogeneity that you get. So I mentioned using CT. Here's an example where you can see that there's something looks a little bit different where the blue arrows are here, and what was really nice with this one is if you superimpose that sagittal view on top of the CT, you can see that that's where the fissures are. And these were slightly expanded fissures, and I think one of the traps when you move from planar to SPECT imaging is that the ventilation tends to go a bit further to the periphery of the lung, to the fissure, than you get with perfusion scanning. And the reason being that the bronchial circulation is going to be supplying that outer part of that segment. And so you sometimes get a bit of a gap between ventilation and perfusion for purely physiological reasons which we understand. So we published this special issue of the Journal of Seminars in Nuclear Medicine back in 2010 at the request of Len Freeman, and this was all about going to SPECT VQ imaging, transitioning, parameters, protocols. If you want to know how to get started, have a look at that issue. And then we were invited back 10 years later to talk about the non-PE examples. And so once you're confident doing your SPECT imaging, then this is the next one to go to see what else you can do with it. Some of those applications are things like, as I mentioned, prior to surgery, looking at the functional contribution of the different lobes or segments, some cardiopulmonary work that I'll show you, heterogeneity in asthma, treatment planning, mismatch in paediatric conditions where you've got some developmental anomaly. We've done that quite a bit. And lots of different things that you can think about to investigate. One of the fun ones we did was with our cardiologists, looking at the change that posture has on patients' perfusion and ventilation patterns when they've got suspected pulmonary arterial hypertension. So we did two studies, a VQ scan injected upright and a VQ scan done supine on different days. And we then segmented that by the lobes. And the first thing I looked at there was what's the normal values for the function of the lungs. Now, if you talk to the cardiothoracic surgeon or the radiologist, they'll say the right middle lobe does about 10% of the function or whatever, but actually when you measure it, it's not that much. And so when there's a debate in the lung cancer meeting about whether to take out the right middle lobe as well as the right upper lobe for a lung cancer, I kind of say, why are you quibbling about this? It's 6%. Just if you want to be really certain you've got an R0 resection, take it out. And so we looked at upright normal ventilation and supine normal ventilation and perfusion. I don't think there's many other ways that you can do this because you've got the ability with the Technigas and MAA to freeze the distribution at the time of administration, and then that doesn't vary whether you're supine or upright. And so I mentioned the study we did, and I won't go into much detail about this, but looking at the differences here, all of us without any pulmonary arterial hypertension will change due to gravity the perfusion pattern. So when we're upright, we perfuse the basal lobes more, and ventilation matches that as well. What we found in the patients who have pulmonary arterial hypertension is rather than having a gradient that changes there, you can actually see that they didn't change, the ratio of ventilation to perfusion did not change going from supine to upright. And what that told us was that they've lost the microtonicity of the vasculature, that it wasn't able to adapt, and that's due to the constant hypertension that the lungs are under from the right heart. And so that was a very interesting study which was correlated with catheters and in blood gases and all the rest of it. But I'm just doing this to show you some of the sorts of things you can start to investigate. When you move to 3D and you've got this sort of ideal agent that's fixed for ventilation and fixed for perfusion. I'll finish by just mentioning a little bit about dosimetry and lung imaging, because that's something that we do get asked a lot. And I think suffice to say that both the Technigas and the MAA scans are pretty low dose studies, and if you're doing a CT as well, you're adding another 2 millisieverts or thereabouts, probably just doing a thoracic CT at normal tidal breathing. But where it's important, I think, is when you're asked about the young female who's pregnant, who's come into the emergency department. Should they do a CTPA? Should they do a SPECT lung scan? Should you do ventilation? And there's a lot of people think, well, no, you don't do ventilation because you don't want to irradiate the fetus. Now, the reason for that is that if you're using a DTPA, the DTPA clears into the bloodstream through the epithelium, and you'll then be excreted from the bloodstream via the kidneys into the bladder, and you'll irradiate the fetus. You don't get that with Technigas because it stays fixed. So that dogma is completely misleading when you're using a fixed agent like this. The real decision to make if you're talking about the young female is the breast dose. The breast dose is highest for a CT scan and is vanishingly small when you're doing technetium VQ imaging. So that's our test of choice. We do both ventilation and perfusion. Often we use a half dose because that's just prudent, but we do ventilation perfusion in preference to CT in the pregnant or the young female with a vulnerable breast. So the key points there, that it doesn't clear via the kidneys, so you don't have to worry about fetal doses anywhere near as much, and it's the female breast that's worrying. So the strengths and weaknesses I see of the VQ scan, we get 3D functional information about regional ventilation and perfusion, and when you talk to the respiratory physiologists and physicians, they are thinking about pulmonary function tests, FEV1s, peak flow rates, all those sorts of things. It's a global measure. The thing that the VQ scan does is gives you regional measures, and there's not many other ways to do that. It's non-invasive mostly. It's applicable to people with contrast allergies or poor renal function. It's a low radiation dose, and the CT adds quite a lot. And we routinely look at attenuation and scatter-corrected ventilation and perfusion scans using CT to drive that. Downsides are the limited resolution of a SPECT system, around between 10 and 12 millimetres, typically for technetium. We don't do much in the way of dynamics that you can do with, say, breathing in hyperpolarised gases or something like that. You need a suitable ventilation agent, and as I say, historically, I hope this is the last time I'm talking to you about this when you don't have one. And we are using ionising radiation. So with that, I hope next time we meet, you'll be joining us all, the rest of the world, in the 21st century with lung imaging. Thanks very much.
Thank you, Professor Bailey. We'll try to keep questions to the very end. Our next speaker, this is an international symposium, and we wanted to have someone from France. And I contacted Professor Salon and said, do you have, who should we ask to speak on behalf of this symposium? And he kindly volunteered. Professor Salin he's the president of the French Association, so he was the man to go to. And besides that, his group at the Breast is well known, and the publications that are coming out of that in lung imaging is fantastic. It's I'm particularly grateful for Pierre-Yves for making it here. One of the most important things that we do is try to interact with our referring physicians. Pierre-Yves is multitasking today. He's just flown in to share with us. He's at another conference in Montreal. He and his colleagues, sharing the good news about nuclear medicine and lung imaging. But I won't delay any further because we've got a lot of information to share today. Pierre-Yves, please. Thank you.
Thanks a lot, James. I will ask Dale explain to us that there are many ways to use the evaluation of the regional functional pulmonary, and I will focus my talk on the pulmonary embolism because it's one of the main indications of the use of VQ scan, and we will see that probably we will have some surprise because we have new things probably which will be interesting to support. My disclosures. PE is a common situation, and both misdiagnosis and excess diagnosis may have major consequences. Indeed, an untreated PE is potentially fatal, but on the other hand, anticoagulant therapy has constraints and a risk of bleeding, and especially if it is a trend towards extended duration of treatment in most of patients. So, reaching diagnostic certainty is required for all patients. PE diagnosis does not rely on a single test, but on the use of diagnostic algorithm, including sequential use of clinical probability, D-dimer testing, and imaging tests. In patients with a high clinical probability, and in patients with a non-high clinical probability but with positive D-dimer, imaging tests are required to rule out or confirm the diagnosis. There are currently two widely validated imaging modalities for PE diagnosis, VQ scintigraphy and CT pulmonary angiography, which are based on a different approach. VQ scan allows a functional approach of PE by the visualization of the consequences of PE on a lung perfusion, whereas CTPA enables an anatomic approach of PE with the visualization of the clot itself. So let's talk to the VQ scan for acute pulmonary embolism. VQ planar scan was the first non-invasive procedure validated for the PE diagnosis in replacement of pulmonary angiography. Ventilation is required after inhalation of inert gases such as krypton in Europe or xenon in US, or radiolabeled aerosol, mainly Technegas outside of the US. Perfusion is imaged after intravenous administration of radiolabeled macroaggregated albumin particles, which are trapped in the lung capillaries according to the regional blood flow. It is important to recall that the hallmark of PE with VQ scan is a mismatch perfusion defect that is areas with absent perfusion but preserve ventilation. Ventilation agent have advantages and limitations. Xenon and krypton are true radioactive gas, but xenon has a high dosimetry and does not allow 3D acquisition. DTPA is a wet aerosol with bad quality images, especially in case of bronchopathy. Technegas and krypton give high quality images, allowing easily, as it was said by Dale, a 3D acquisition. As you know, two different protocols are possible for imaging acquisition, planar 2D imaging and SPECT imaging. By using a 3D imaging, VQ SPECT has an inherent technical advantage over conventional 2D planar, though its ability to eliminate overlap of activities, to better characterize the size, the shape, and the location of the defects, and to visualize the medial basal segment. Furthermore, SPECT CT cameras enable simultaneous acquisition of a low-dose CT, which allows for correlation of VQ defect with morphologic features on CT and allows for a differential diagnosis. VQ SPECT has already been widely adopted for PE diagnosis in countries where krypton gas or Technegas were available. In a survey performed among more than 300 facilities from Australia, Canada, and France, already back 8 years ago, more than 2/3 of centers performed SPECT rather than planar images for PE diagnosis. In order to decrease the specificity and to increase the specificity and decrease the rate of false positive results, SPECT images can be combined with a low-dose CT that may visualize non-thromboembolic findings. Here is an example of a patient with suspected PE. SPECT images show a segmental perfusion defect in the right upper lobe with relatively preserved ventilation. Just based on the VQ SPECT images, the scan would have been read as positive for PE. However, the CT scan showed parenchymal lung lesions, which were actually radiation changes. However, using only a low-dose CT instead of the ventilation significantly increased the rate of false positive result. For example, this perfusion SPECT scan demonstrates multiple perfusion defects without significant abnormalities on CT. So by omitting the ventilation scan would be interpreted as positive for PE, while all perfusion defects were actually matched with ventilation defects. There is a high risk of false positive when substituting ventilation images by a low-dose CT scan alone. According to the various published studies, up to 20% of negative VQ scan would be falsely positive by substituting the ventilation imaging by a low-dose CT. As you know, PE has been reported to be a frequent complication of COVID-19 disease. In one hand, the diagnostic of PE on lung scan relies on the recognition of mismatch defect. On the other hand, the ventilation procedure increases the potential risk of the contamination by aerosol secretion to a healthcare worker. As a result, a variety of conflicting strategies have been proposed regarding performances of lung scintigraphy in COVID-19 patients. Some have proposed to omit the ventilation and to only perform a perfusion scan or a perfusion SPECT CT. Others have recommended to systematically maintain standard VQ procedures with appropriate aerosol precaution for healthcare workers. Finally, some have proposed an intermediate approach with a standalone perfusion planar or SPECT CT scan, followed only when necessary by a ventilation scan. However, there was no factual data in this specific population to support a recommendation to the nuclear medicine community. A national registry was created in collaboration with the French Society of Nuclear Medicine, and in France to collect lung scans performed in COVID-19 patients for suspected PE. A retrospective review of VQ SPECT CTs was conducted by sequentially using only perfusion SPECT plus CT, and ventilation perfusion SPECT plus CT images. Out of the 145 scans, PE could be excluded using only perfusion SPECT in 90% of patients. When adding the CT scan, 38% more scans became diagnostic. All perfusion defects could be explained by non-PE morphologic findings. So overall, perfusion SPECT CT would have allowed to exclude PE in 57% of patients. However, out of the 63 patients with an abnormal perfusion SPECT CT, the addition of a ventilation scan allowed to exclude PE in 31% of patients. Importance of ventilation comparison is also particularly true for chronic thromboembolic disease. Here, choose an example with perfusion scans demonstrating multiple segmental perfusion defect, suitable for chronic thromboembolic pulmonary hypertension. However, when we compare with the ventilation, the first example with an almost normal ventilation is typical for CTEPH. In contrast, the second example showed multiple matched defects. This patient had a pulmonary hypertension secondary to parenchymal lung disease. VQ scan interpretation is based on the number, the size of mismatch defect, and when using planar VQ scan, results are classified according to the criteria established by PIOPET study. Basically, results can be classified in three categories: normal perfusion scan, which rules out PE diagnosis, high probability scan, which confirms PE diagnosis, and between those two categories, the low and intermediate probability scans, which are usually combined in a single category, reported as non-conclusive or unconclusive, for which further testing is required. Here is an example of a validated diagnostic algorithm for PE diagnostic using planar VQ. In patients with an inconclusive VQ scan, a lower limb compression ultrasonography is usually performed, which allows, in combination with the clinical probability, to conclude in a majority of patients. So, obviously, the main constraint of diagnostic strategy using the planar VQ scan is that they are complex and more difficult to apply. But, on the other hand, it is important to remember that these strategies have been strongly validated for excluding PE in several large management outcome studies. The recent American Society of Hematology guidelines for VTE diagnostic even states that VQ scan is to be preferred over CTPA to limit radiation exposure in some group of patients. So, in other words, it works well and it is safe to manage in patients with suspected PE using a validated strategy based on VQ scan. To resume, what are the strengths and the weaknesses of planar VQ? Especially as compared with CTPA, strengths include a strong validation in prospective management outcome studies, no contraindication or side effects, low radiation dose, especially to the female breast. On the other hand, the main limitation are the high risk of inconclusive results resulting in complex diagnostic algorithms. A VQ planar scan does not allow to propose alternative diagnosis, and the test is not widely available. For VQ SPECT interpretation, a binary reporting approach is widely accepted. The rationale for transitioning from the probabilistic to the binary approach is the higher diagnostic performances of SPECT, the ease of use for nuclear medicine physicians, a greater understanding of clinicians, the aim of simplifying diagnostic strategies. A diagnostic cutoff of one segmental or two subsegmental mismatched defects is widely used. This threshold was initially proposed in the SNMMI guidelines, and it was shown to provide optimal sensitivity and specificity, and was already the most commonly used criteria in our survey 8 years ago. What is the diagnostic performances of VQ SPECT CT imaging? We recently conducted a systematic review on VQ SPECT for PE diagnosis. Based on the analysis of the 13 accuracy studies identified, we observed that the probabilistic approach was left, binary reporting criteria were used in all studies, and there were a low rate of inconclusive results, less than 5%, which lead finally to the accuracy indices very high. However, there is currently no prospective management outcome study and no randomized trial comparing with other modalities. So, there is currently no validated diagnostic algorithm with VQ SPECT, which likely explains why the clinician guidelines remain cautious with the VQ SPECT. So, to conclude, with the VQ SPECT, it is a promising alternative to CTPA and planar VQ with several advantages, including no contraindication, low radiation dose, possibility to provide alternative diagnosis with the low-dose CT, low rate of inconclusive tests, potentially simple diagnostic algorithm and no over-diagnosis. On the other hand, the test is less available than CTPA, like for the VQ planar, and then currently no validated management outcome study, but they are coming. Now let's move to the second part, maybe less known, on the role of the VQ scan in the follow-up of PE. The cornerstone supporting the use of VQ scan in the follow-up of PE is the residual pulmonary vascular obstruction, RPVO. RPVO can be defined as an incomplete repermeabilization of the pulmonary arteries after acute PE. This graph shows the percentage of patients who demonstrates at least 10% of RPVO over the year after the first episode of acute PE. As you can see, RPVO slightly decreases over time, but remains frequent, around 50% at 3 months, and still 30% at 1 year. So, given the frequency of RPVO after PE, the first clinical utility of a follow-up VQ scan after 3 to 6 months of anticoagulant therapy is to have a reference scan in case of suspicion of recurrence. Indeed, suspicion of PE recurrence is very common. 1 out of every 2 patients with a first episode of PE will present with suspected PE recurrence. And this is often a complex diagnostic and therapeutic situation for clinicians. CTPI is not optimal as a routine scan in the follow-up of PE. Mainly, the interpretation and comparison with previous scans are complex. In contrast, VQ scan is the imaging modality of choice for the follow-up of PE and the assessment of PVO. However, post-embolic sequelae have the same pattern as acute PE, which is mismatched perfusion defects. Therefore, a baseline VQ scan at completion of anticoagulant therapy has a high diagnostic utility in case of suspicion of PE recurrence. For example, in this case of a patient with a history of massive PE and CTPI, referred for a VQ scan for suspected PE recurrence, the VQ shows multiple mismatched perfusion defects, and it is actually impossible to say whether it is a PVO, new PE, or both. However, if a baseline scan is available, interpretation becomes straightforward and easy, as you have to look for the new perfusion mismatch. In this case, imaging were similar without new defects, ruling out the diagnostic of PE recurrence. Then, what is the clinical significance of a PVO after PE? Numerous of studies have shown that residual pulmonary vascular obstruction after completion of 2 to 6 months of anticoagulation was an independent risk factor for PE recurrence. In this recent meta-analysis, Beccatini and Cole confirmed that increased risk of recurrence VTE in patients with RPVO on the VQ scan with a pool-odd ratio of 2.2. And of course, the resultant question is, could the RPVO be used to tailor the duration of anticoagulant therapy? As discussed earlier, the decision to continue or discontinue anticoagulation after this period should be individually tailored according to the risk of recurrence VTE and balanced against the risk of bleeding. In that respect, predictors of recurrence, and especially RPVO, could drive strategies for secondary prevention. There is only 2 to 3-fold increased risk, so the decision will not be only based on the PVO, but it may be taken into account in association with other predictors. In order to better understand the role of VQ scan, we will conduct, in that way, a large prospective cohort study granted by Cyclomedica, and I will thank James for that, which aims to better describe the link between RPVO and the recurrence of PE over a 2-year follow-up, because I think we will have a very great place in that cases. After the first episode of PE, up to 50% of patients will present with post-pulmonary embolism syndrome, which is defined as new or progressive dyspnea, exercise intolerance, or impaired functional status after at least 3 months of anticoagulation following acute PE. So this is a very common situation, and among them, only 1 to 4 will be referred for chronic thromboembolism, pulmonary hypertension confirmation. VQ scintigraphy is the imaging modality of choice to exclude CTEPH. The test has been highly sensitivity, so a negative VQ scan rule out CTEPH. On the other hand, patients with a positive VQ scan have to be referred to pulmonary hypertension experts for confirming the diagnosis with pulmonary angiography on right heart catheterization. I will present the same case I showed you before, and it is very important to note that it is the same patterns that we would like to have to confirm or to exclude the CTEPH from the dyspnea after PE, acute PE. To conclude, VQ scintigraphy will have a major role to play for the diagnosis of acute PE, with especially an advantage on the radiation dose and possibly on the risk of overdiagnosis. VQ SPECT imaging opens new perspectives to decrease the proportion of non-diagnostic tests, simplify the diagnostic algorithm, and provide differential diagnostic for PE. PE, VQ scan also has a major role to play to play in the follow-up of those patients. A reference scan at completion of anticoagulation has a high diagnostic utility. PVO is a risk factor of PE recurrence and may be used to tailor the duration of anticoagulation. And of course, VQ scan is the imaging modality of choice for the screening of CTEPH and may also be useful for the management of patients with post-PE syndrome. I would like to thank my team in Brest and thank you for your attention.
Thank you so much, Professor Salon. I have a few more extras there for you. We all recognize the importance of educating our referring physicians, and in doing so, we've been partnering with McMaster University in Canada to advance some different applications for the use of functional ventilation imaging. Our next speaker would have loved to have been here today, Dr. Sarah Svensson. Sarah has she's been working with our company for a few years at McMaster University, advancing some of their own work at McMaster. I saw Sarah present at Barcelona last year at the European Respirology Society meeting, and she's a fantastic presenter. She most recently also participated in the Canadian Association of Nuclear Medicine Symposium online, and I encourage you all to go and watch that presentation as well. Sarah's flight was canceled last night, so the society was kind enough to kind of rearrange the program so she could still present online. Sarah?
Thank you very much, James, for that kind introduction, and good afternoon, everyone. It's an absolute pleasure to speak at this symposium, and as James mentioned, I very much wish I could have been there in person with you all. I do have one relevant conflict of interest, and that's that I've received research grants paid to my institution by Cyclomedica to support the studies that I'll be presenting today. So I'm going to speak to you about two novel research applications of Technegas SPEC that we've been exploring at the Firestone Institute for Respiratory Health at McMaster University in Hamilton, Canada. And we're applying Technegas SPEC to understand the prevalence and clinical relevance of abnormal ventilation prior to lung cancer resection surgery and following recovery from non-critical COVID-19. So I'm going to split my talk up into two parts to speak to both of these research studies. And I'll start with lung cancer resection surgery. So as we know, lung cancer is a leading cause of cancer-related deaths. And curative intent lung resection surgery is the optimal treatment option for early-stage lung cancer. However, postoperative pulmonary complications are frequent adverse events with an incidence ranging between 15 to 40%. And these complications, they lead to substantial patient morbidity and mortality, and they have a significant clinical and economic impact. And despite this, these complications remain inadequately predicted. And various clinical studies have identified various or numerous risk factors for postoperative pulmonary complications, the most frequent being older age, decreased lung function, smoking history, and prior diagnosis of lung disease, including COPD. And I'm showing here two guidelines on the selection of patients with lung cancer for surgery, one from the British Thoracic Society and the other from the American College of Chest Physicians. And I won't go through these in detail, but what I do want to point out is that these guidelines recommend preoperative lung function assessment by pulmonary function testing, and that both FEV1 and DLCO be considered in the risk stratification and decision to resect. But neither guideline is recommending the functional assessment by ventilation imaging. And if we revisit the risk factors that I had just introduced to you on the previous slide, in patients without lung cancer, all of these risk factors have been associated with abnormal ventilation assessed by various ventilation imaging modalities. So this presents an opportunity for Technegas SPEC that we were quite interested in. And towards this opportunity, we designed a 6-week prospective observational study to address 2 research questions. The first being, what is the prevalence of abnormal ventilation quantified by Technegas SPECT prior to lung resection surgery? And the second being, does preoperative ventilation quantified by Technegas SPECT predict the occurrence of postoperative pulmonary complications or clinical outcomes following resection surgery? So to address these questions, we're enrolling patients at the time of a resectable lung cancer diagnosis. These patients then undergo preoperative Technegas ventilation SPECT about a week before their lung resection surgery, and then we follow these patients to document their postoperative pulmonary complications and clinical outcomes. And today I'll be presenting an interim analysis of this study in the 72 patients that have completed their assessment so far. And I'm showing here 3 representative patients who have underwent Technegas ventilation SPECT prior to their lung cancer resection surgery. The first case here is a 62-year-old female with no history of lung disease and normal lung function according to standard breathing tests. And agreeing quite nicely with this, we see this nice homogeneous ventilation pattern visualized by Technegas SPECT. And the second case presented very similarly with respect to their clinical characteristics. So they had no history of lung disease and completely normal lung function according to standard breathing tests. But the Technegas ventilation scan shows us a very different picture. As we can see here, there's these large focal ventilation defects that were observed. In addition to these, we see this heterogeneity of the ventilation signal in this patient's upper lobes. So this case highlights the sensitivity of Technegas SPECT to subclinical lung disease. And the third case here is a 65-year-old male with COPD. Given his COPD diagnosis, as we would expect, he had severe airflow obstruction and had a moderate reduction in the diffusing capacity of his lung. But what was quite striking with his ventilation scan was the regional predominance of the ventilation defects. So we see here that the right lung was predominantly defect, not being ventilated, whereas the left lung was relatively well ventilated. So this regional information isn't provided, of course, by our standard clinical breathing tests. And I'll come back to these cases in a few slides. But I do quickly want to highlight that we can quantify these images using various biomarkers. The one that I'll be focusing on today for this study is the ventilation defect percentage. And essentially what this is it quantifies the percentage of the lung that isn't being ventilated. So shown here in a healthy individual, we would expect a low ventilation defect percentage. So in this case, it was 12%. And in patients with obstructive lung disease, we can see that this VDP is much higher, reflecting this region of the lung, this large region of the lung that isn't being ventilated. So in this case, the VDP was 62%, indicating that 62% of this patient's lung was not being ventilated. Now, we wanted to evaluate if Technegas SPECT VDP was sensitive to underlying lung disease in our population. And what this plot shows is I've got the Technegas SPECT VDP plotted here on the y-axis, and then I'm plotting the VDP for patients with no history of lung disease, patients with asthma, and patients with COPD. And what we observed was that there was a greater ventilation defect burden in patients with COPD compared to those with asthma and no history of lung disease. But I do want to highlight even this heterogeneity, this wide range of VDP in patients with no history of lung disease, and we'll come back to that. And what these plots show is that increased ventilation defect burden was associated with worse airflow obstruction quantified by FEV1 over FVC, and also reduced diffusing capacity of the lung quantified by DLCO. Okay, so what was the prevalence or the modern prevalence of abnormal ventilation prior to lung cancer resection? And this plot shows the preoperative ventilation defect percentage for the 72 patients we've evaluated thus far. We established this upper limit of normal for VDP based on an independent healthy control group. And what we observed was that 53% of participants had abnormal ventilation prior to lung resection surgery. And of these 53% of patients, 45% of those had no history of lung disease, and 24% had absolutely normal FEV1 and DLCO. So we were quite intrigued by this high prevalence of abnormal ventilation in patients with no history of lung disease and in those with normal lung function according to standard lung function tests. And this group of patients would be considered relatively low risk for resection surgery. But really the important question is, what's the clinical relevance of this observation? Is abnormal ventilation detected and quantified by Technegas SPECT VDP important to patient outcomes? And to evaluate this, we've meticulously documented postoperative pulmonary complications and clinical outcomes. I won't go through this in detail, but I will just briefly highlight that about 13% of our patients had a pulmonary complication. Mean length of hospital stay was 3 days, but you'll see this wide range here from 1 to 26 days. 15% of patients presented at the emergency room after discharge following the resection surgery. So let's revisit the 3 cases that I had introduced to you earlier. And now I'm showing here the resection details and their postoperative complications and clinical outcomes. Starting with the patient with normal ventilation, this patient went on to have a left upper lobe wedge resection and did very well post-surgery, only spending 2 days in hospital with no complications. The comparative and contrasting case with abnormal ventilation had a lingulectomy and had a much more complicated post-operative period, spending 6 days in hospital, ultimately ending up with pneumonia and which required an ER visit and hospital stay. And then the final case with COPD and this right lung predominant ventilation defect ended up having a left pneumonectomy due to the invasiveness of their cancer, and unfortunately had a prolonged ICU stay and ultimately passed away of respiratory failure. But now moving away from our cases, let's look at the postoperative length of hospital stay in our population at large. And what this plot shows is that those patients with abnormal ventilation required a longer hospital stay than those with normal ventilation prior to their surgery, so 4 days versus 2 days respectively. And considering VDP as a continuous variable, we observed that increased VDP, so greater defect burden, was associated with a longer postoperative length of hospital stay. And while this univariate relationship is quite encouraging, what's most important to consider is the predictive value of Technegas SPECT VDP relative to the known risk factors I had introduced to you. And to evaluate this, we undertook and we performed multivariate linear regression analysis. And what this analysis revealed was that Technegas SPECT VDP is an independent predictor of postoperative length of hospital stay, having a greater effect than known risk factors including age, smoking history, diagnosis of COPD, and standard lung function metrics of airflow obstruction and diffusing capacity. So I'll briefly wrap up this section by summarizing the key results of this interim analysis. We're reporting that ventilation defect burden quantified by Technegas SPECT VDP is increased in patients with COPD, and it's correlated with standard clinical measures of airflow limitation and diffusing capacity. Abnormal ventilation is prevalent prior to lung resection surgery. Preoperatively, Technegas SPECT VDP was abnormal in 53% of patients, 45% of whom had no history of lung disease, and 24% of whom had normal FEV1 and DLCO. And most importantly, higher Technegas SPECT VDP was associated with a longer postoperative hospital stay. So to conclude from these results, we're concluding that abnormal ventilation quantified by Technegas SPECT VDP is indeed prevalent prior to lung cancer resection, and we think it's clinically relevant, or the data suggests it certainly is clinically relevant, as Technegas SPECT VDP was an independent and stronger predictor of postoperative length of hospital stay than established clinical risk factors. In the last few minutes, I'm going to switch gears to a study that we are just wrapping up, evaluating ventilation following recovery from non-critical COVID-19. And of course, at this stage in the endemic, COVID-19 requires no introduction, so I'll jump right into things. Very early on in the pandemic, we undertook a study to investigate the prevalence and clinical relevance of ventilation and perfusion abnormalities evaluated by VQ-SPECT, specifically in patients with no history of lung disease. And we evaluated them at 1 month and 6 months after recovery from non-critical illness. So we studied 3 groups of patients, never COVID-19 controls, post-COVID-19 individuals who recovered at home, and post-COVID-19 individuals who required hospitalization during their acute phase of their infection. And these 3 study groups have completed 2 imaging sessions separated by 5 months. And for those who had COVID-19, these imaging sessions were completed 1 month and 6 months after recovery. But for the purpose of this talk and our time constraints, I'll just focus on the 1 month data. And what I'm showing here are 3 representative patients. I'm showing the 3D ventilation and perfusion images for post-COVID hospitalized, post-COVID home isolated, and never COVID-19 control patient. And the reason for showing these is I wanted to emphasize, or I hope you can appreciate, the heterogeneity in the ventilation and perfusion patterns in the post-COVID individuals compared to our never COVID-19 control case. And to look a little bit closer at these representative cases, I'm showing here a representative slice where we can see these matched VQ defects being spatially related to ground glass opacities on the CT scan. And we also observed similar matched VQ defects in patients who recovered at home from COVID-19. So again, here we've got these matched VQ defects co-localized to ground glass opacities on CT. So we had our nuclear medicine physician quantify or report the prevalence of VQ defects in our patients, and also characterize these abnormalities. This is a very, very busy slide, so I'll focus in on one key result that I want you to take from this, and that's that 88% of hospitalized and 44% of home isolated participants were reported to have ventilation defects, compared to 30% of never COVID-19 controls. So there was a higher prevalence of ventilation defects in post-COVID hospitalized individuals compared to our never COVID-19 control group. And now, as we identify this abnormal ventilation being prevalent following COVID-19, we wanted to dig a little bit further, and we quantified the ventilation heterogeneity of the Technegas VSPECT signal. And that data is plotted here. And what we observed was that increased ventilation heterogeneity assessed by Technegas SPECT was observed in our hospitalized cohort compared to our never COVID-19 controls. Now again, the key question is, what is the clinical relevance of this signal that we're able to detect? Is ventilation heterogeneity observed post-COVID-19 by Technegas SPECT COV associated with symptoms and exercise capacity? And those results are summarized on this slide. And what we observed was that increased ventilation heterogeneity was associated with patients reporting being more breathless, patients reporting more respiratory symptoms, patients having more exercise limitation, and a lower oxygen saturation. Okay, again, I'll conclude the key results from this study evaluating Technegas SPECT 4 weeks after recovery from non-critical COVID-19. We observed that ventilation defects were more prevalent and ventilation heterogeneity was greater in individuals who were hospitalized at the time of acute infection compared to our never COVID-19 control group. And that post-COVID-19 ventilation heterogeneity was associated with patient-reported respiratory symptoms and decreased exercise capacity. And the conclusion we're drawing from this is that Technegas SPECT may be a valuable tool for clinicians in the management of patients who are being evaluated after COVID-19 or any viral infection for that matter, as it does permit an objective evaluation of lung function impairment that may underlie and explain post-COVID symptoms. And this is of particular interest because what we know from the literature now is that the majority of these patients present absolutely normal on standard pulmonary function tests. So this offers us a more sensitive tool to identify objective abnormalities to support these patients' symptoms. And of course, as I alluded to you, we're following these same individuals at 6 months, so we're currently in the process of evaluating the temporal trajectories and long-term consequences of these early functional abnormalities that I've just summarized. Okay, I'm over time, so I'm going to end quite promptly here and just say that I hope that the data that I've highlighted from these 2 research studies provides evidence and opportunity for novel applications of Technegas SPECT to improve patient outcomes and patient management. Thank you very much.
Thank you, Dr. Signitzin. I know that we've reached the time limit, but our on-site presenters are more than willing to stay back. For if you have some questions, please come up, and we'd be more than happy to. And if you have any questions for Sarah, we're more than happy to get your contact details and connect you with Sarah after this presentation. Thank you all. Thank you.